Welcome back to this exciting day. My name is Natalie Pageler. I am the Chief Medical Information Officer at Stanford Children's Health. So anybody who is interested in applying all the great learnings today to pediatrics and obstetrics, please come talk to me afterwards. I have the exciting privilege of leading this panel today on the responsible implementation of AI in healthcare. We stand poised at a very exciting time to harness the power of AI and advanced data science in clinical medicine to advance our understanding of disease, our diagnosis, our interventions, and our promotion of well-being and healthcare overall, or at least that's what ChatGPT told me to say. I have three amazing presenters today. They are each going to come up one at a time and give you a quick overview of some of their work in this important area. And then at the end, we'll have time for a discussion and question and answer. If you have questions in the audience, you're going to be able to come up and ask them. If you are in the virtual audience, please use Slido, and we will ask them for you. And with that, let's kick it off with our first presenter, Dr. Nigam Shah, who is Professor of Medicine at Stanford, as well as the new Chief Data Scientist for Stanford Healthcare. And he's going to tell us a little bit about what that means and his amazing work.
Thank you. All right. So for some of you, I met you yesterday in San Diego. This will be a different talk, so it won't be the same slides. So what I'm going to talk to you about is our thoughts right now on how do we create fair, useful, and reliable models in healthcare. And this is a backronym because we wanted it to sound cool. It stands for FURM, F-U-R-M, fair, useful, reliable models. So we set up a team inside of Stanford Healthcare to address this problem, which I'm sure a lot of you are familiar with, that there's hundreds of models that are built. In the past 2 years or 2.5 years, faculty on our campus have published more than 500 models, classifiers, and predictors. 2 have been deployed in our healthcare system, and 1 of them is not even published. So a very small percentage deployed for routine use is kind of an understatement. And it's already starting to become clear that realizing value from the use of AI to guide care remains elusive. We've been talking about it for quite some time. Natalie and I were just joking that we're so far up the hype cycle, we might reach escape velocity and end up on the moon or something. I mean, it's pretty dramatic. So what do we do about it, right? I mean, it's easy to come up with fun things to complain about. So we set up this new team, which does 4 things. And I'll just put those 4 things here, and then we're going to go through them one by one. The first is thought leadership in responsible AI in healthcare. And I say that because there's enough work building algorithms, burning GPUs, and emitting carbon. There's not enough on taking these things into the clinic. Second, the thing that I mentioned, FURM, fair, useful, reliable models, and how do we ensure that that is the case? So we're setting up processes to do that. And then, of course, we need to get the infrastructure and business processes around a 1,000-person IT department and its interactions with another 14,000 human beings that are part of the healthcare system to make sure that we are AI ready. It's very easy to spell AI. It's really hard to do it. And then we want to make sure that we identify and execute projects that have enterprise value. Because otherwise, if we just keep doing science projects, it's not sustainable. It has to lead to real benefit in quality of care, value of care, other financial metrics. So this is our operating plan for the health system for FY23. And quality and safety and health equity are top, followed by patient experience, employee engagement, wellness, and financial strength. So it has to connect to one of these things. So that's sort of the overview. So let's just jump in. So this is a Mercedes-Benz logo that I've used quite often to get the point across. That there's an interplay amongst models, the capacity of taking actions, and the actions that we take. So the model policy and capacity and action. And I'll give you a concrete example. The pooled cohort equation is a model with about 9 or 10 inputs and produces a real valued output, which is the probability of having a heart attack in the next 10 years. That's the model. When I say model, I mean an equation that takes any inputs and produces a real valued output. Now, there's a policy that says if that output from the model is above 7.5%, thou shalt prescribe 40 milligrams of atorvastatin. And we can pretend that our capacity to prescribe statins is unlimited. And the benefits and harms of the action, as in ingesting 40 milligrams of atorvastatin, has been studied to death, like thousands of papers. Okay? But this is one model for which we have such complete flesh out of all 3 parts. For most other things, you get 2 out of the 3. If you have a model that predicts transfer to ICU, like that's awesome. But if your ICU is full, you have no capacity. So it doesn't matter what you predict, how often you predict, or how good you are. And so we need to understand this interplay, and good AI-guided work happens at the intersection of all of these 3 things. So we have about 27 or so papers studying this interplay. And then based on that, we developed a process or a way to assess if any AI-guided work situation is fair, useful, and reliable, or that model is going to end up being fair, useful, and reliable. Sometimes I often use the M for fair, useful, reliable, and has monetary value. And monetary value not in the sense of extracting a profit, but being sustainable. Because if it's not sustainable, it's not going to happen. And so it's a bunch of steps. They're color-coded. It's about 13 steps. You could make them 10. You could make them 15. It really doesn't matter. But the point is, we need to start with what the real need is, make sure we have an ethical concerns review, and do the business case up front. It's one of the few situations where you'd see the word ethics review and business case like next to each other. But they go hand in hand. Like if it's unethical, it's bad business. And if it's ethical and not sustainable, you're not going to be able to do it. So you got to do both up front. And then the first tranche of work is to figure out like what and why we're doing, then figure out the how, and be honest in our assessment of monitoring and making sure we answer the question, did it work? Because if it didn't, we got to shut it down. How many reports do your EHR systems generate that nobody looks at? For those of you in health IT, you probably know that the number is in the thousands and not hundreds. All of that is a cost to healthcare. Every model that runs that someone in IT has to babysit and nobody follows up on it is cost to the health system. So we want to make sure that we're spending our mental energy in a way that matters. And I want to highlight this one particular step that people talk about IT integration and workflow integration all the time. We add a third step, which we call organizational integration, as in which vice president is going to own this pony long term. When it breaks, you got to fix it. When the workflow doesn't happen, you got to go yell at somebody. And if it is not working, someone has to make the hard call of shutting it down. And we want to identify that business leader up front. So we've done about 8 or so assessments to date, and they come out with a report, a written report, and a recommendation saying, if you do this, this is what we anticipate will happen. We also do a little simulation, those green steps, where it quantifies that if the model flags some number of patients sampled from your own data, and this is your workflow with so many steps and certain failure probabilities along the way, if you run 500 days of simulation, how much of that utility that's promised on paper can you achieve, can you realize? Because often there's no staffing to follow up with all the flags and alerts that you're throwing up. And then you're not going to realize anything. And so that assessment in silico is something that we're quite happy about. And the libraries to do that are public, published under a nice acronym called A+, so you should be able to find it. All right. And then I talked about the processes and infrastructure for being AI ready. I mean, you know, the thing up there, the joke my friend Nikesh Kotecha makes is like we're searching for this elusive ikigai, which is a Japanese concept of what you're good at, what you value, what's possible, and all of that. So that we have on-prem AWS, Azure, GCP, and we're searching for this elusive ikigai where we can do our things without any problem. And then this is straight as a reproduction from the MLOps paper from the Google folks. Like the machine learning or the AI model is like the black box. It's the tiny piece. There's everything else around it that is necessary to make sure that you get some value of having this. And a lot of places have no processes in place for this bigger part of the solution. And we get too excited about the black box. And then finally, to close out, governance is essential for enterprise value. So this is just a zoom up of that same FY23 operating plan. And the yellow box is highlighting our first project that by pure dumb luck ended up as one of the bullet points on the operating plan. We're building predictors for who is likely to pass away in the next 12 months and use that to guide serious illness conversation planning, which would then result in documentation of goals of care and advanced care planning. And and we were always puzzled, like, what is going on here? Because everything we do leads to less revenue for the healthcare system. But why are people so excited about this? Turns out that it is one of the 5 top-level goals on quality, safety, and health equity that we want to increase the level of advanced care planning for our patients, because it's been proven in RCTs that when people get that, they live longer, they cost less, and have a better quality of life. But how do we do that on a repeatable basis? Like, I can't bank on luck every time to hit one of these bullet points. And so Abhi Pandya, who's here, is helping us figure out all of these processes, and, so that we have systematic needs finding, so that we can pick the problems that matter, and then governance on top of it to make sure that if you have 8 good things and we can only do 3, we pick the 3 that everybody agrees on. So with that, I'll close out and hand it off back to Natalie for our next speaker.
Thanks, Nigam. It's a great start. Now to introduce our next speaker, Dr. Nina Kottler is a practicing radiologist who has been clinically practicing for 18 years and was the first radiologist hired at Radiology Partners. She's served multiple leadership roles there, but currently is the Associate Chief Medical Officer over Clinical AI. Welcome, Dr. Kottler.
All right, thank you, everyone. I'm really excited to be here. And what I thought I would talk to you today about was a little bit about how do you evaluate all of those many AI models. And the data that I have, and most of the slides I have, and the things that I'm going to talk about are really based on our experience in using and deploying AI in real practice. Now, I know that there aren't that many models that are utilized across the US or even in the world. But at our practice, we use a lot of them. And they're used in real life, day-to-day practice. And it's that experience that helps you understand where we need to go and how do we get there. So let's get started. These are my disclosures. All right, so why do I want to talk about creating some standards? Right now, it's a bit of the Wild West out there, whether it's for creating AI, deploying AI, educating about AI, monitoring. There is no standard. And if you guys don't recognize this, this is the Gartner Hype Cycle, which talks about the maturity of any new technology in healthcare. And really what happens, the only way that you get to extensive use or the plateau of productivity where it's really being used is if you create best practices. People need things to be a little more plug and play, and that's what we're trying to do at our practice. So what kind of best practices then do you need to create? Well, as a consumer or a customer of AI, because there'd be a whole different circle for creator, but mostly we're a customer, and so I just came up with a bunch of things that I think we need to create standards for so that we can pass them across the industry, make it easier for everyone to deploy these models. What I'm going to talk to you about today, because we just have a few minutes, is one of them. and that is how to clinically evaluate an AI model. All right, so what I will say is that a lot of people talk about numbers, the ROC curve, and they look at maybe one or two things. That is not relevant. What I'm going to tell you about is a model to provide a step-by-step way to do a clinical live evaluation of these models to know if they're accurate enough on your own data to be worthwhile to deploy. And we're going to go through 2 use cases. These are the 5 steps, but we'll talk through them in the 2 use cases that I provide. And these are actual, we've done a bunch of these, but I'm just going to show you 2 of them today. All right, so now if you're making a decision about you're evaluating use steps, you have to decide what is driving your decision. And for me, and actually the radiologist from the VA who spoke up about it is exactly on target. These models, when you deploy them, rads do not always use them. So what is my measure stick when I'm evaluating if these things are happening or not? I'm measuring it by radiologist acceptance and engagement because that's what's going to get my models deployed when I'm talking about radiology. All right, so let's start with the first example. We were looking at a brain aneurysm model, which looks for brain aneurysms on CTAs of the head. And step number 1. So step number 1 is to evaluate the model performance. Now there's the FDA model performance statistics, and a lot of people will look at those. We do our own. We do our own for a couple of reasons. You can notice that first of all, we analyze more cases, and we look at real-world prevalence. Now prevalence really matters. Prevalence has a significant effect on some of the other things. So if you're just looking at the FDA clearance statistics, you're going to be skewed based on what you think is going to happen. So that's number 1. Number 2 is the FDA clearance data tells you nothing about what it's going to look like on your data. Right? We all know that you could go down the street as a radiologist and read a head CTA just the same if the data is different, but it doesn't always work the same with AI. All right, second thing that is different, a lot of people talk about the sensitivity and specificity of a model. Those are great. But remember, the yardstick that we're using to measure things is radiologist acceptance. Does the radiologist know the sensitivity and specificity? Is that what they're feeling when they are using these models? No, right? It's related to it, but what are they feeling? They're feeling the positive predictive value and the negative predictive value. Those are the ones that are important for your radiologist or your user of the tool. Positive predictive value is when you have a study or when your AI model says that there is a positive result, how often is that right? Right? So in this case, positive predictive value, 52%, meaning only slightly more than half the time when the model tells you there's a positive result, is it actually right? So you're going to get a lot of false positives. That's important. Negative predictive value. Negative predictive value is actually a really interesting one. You know, prevalence of disease is never what they show you in the FDA statistics. It's much less. And in the second example, you'll see even more. We'll talk more about that. But here, the prevalence in our large practice, and we do 11 to 12% of the imaging in all of the US, so we have a very big practice, was 5%. And so it's not that high. That means most of your cases are not going to have a brain aneurysm. So when you as a radiologist are looking at your head CTA and this tells you it's negative, if you are very confident, if this number is high, that it's negative, we found that's the key for rads being more efficient. If they can trust when the study is negative, that's going to outweigh any effect of how fast they go on a positive study. Now, what do you have to know about this? Because these numbers, they're based on some of the other data. They have a significant relationship with prevalence. If your prevalence of disease is low, your positive predictive value is going to be low. If your prevalence of disease is low, your negative predictive value is going to be high. You have to keep that in mind when you're evaluating positive predictive value and negative predictive value. So positive predictive value of 52% with a disease prevalence of 5% is actually very good. Why is that? Well, because positive predictive value also is reliant on specificity. And in this case, the specificity of the model was very high, and even higher than the FDA statistics. So that helped raise the positive predictive value in a case where your disease prevalence, which is always going to be the case, is low or low-ish. Negative predictive value is related to sensitivity. It's hard to detect a lot of changes in negative predictive value when your prevalence is low. But the sensitivity was a little bit less, but not too much less than the FDA clearance. Okay, so that's step number one, evaluate the model performance. And we can talk after if you want about how we specifically do that. All right, step number two, this is a really important one. It's probably one of the most important steps. And this is, did AI enhance detection? People talk all the time about miss rates, like what did the RAD miss? RADs are standard of care, right? AI is not standard of care. We're using AI to augment the radiologist to elevate the standard of care. So we should not be talking about RAD misses. We should be talking about what we call the enhanced detection rate. So you can see here that the RAD detected 41 aneurysms in this almost 1,000 case study, but the AI detected 38. If you combine the two, there were actually 51 that were detected by the RAD and the AI. And so the enhanced detection rate for the radiologist is 24%. It's a big number, right? 24% more patients will be identified that have brain aneurysms that need follow-up. That's a fantastic result. Now, I will say, if you look at this data and you say, well, how do you go from 38 to 51? The RADs would have improved the AI by 34%. So it goes both directions. All right, step number three, find what we call the wow cases. These cases that we as radiologists think are really instrumental in making us trust the model. There's a long trust curve. It usually takes about 6 weeks for a RAD to trust something new with these AI models. We want to shrink that trust curve. We want to make sure that the RADs are engaging with it. So let's find the cases that help make a radiologist feel confident about the capability. So this is a 74-year-old female, came in with acute neural deficit, stroke suspected. Here's the axial CTA, and we're looking at the supraclinoid ICA. Hard to see anything because it's in line, right? Most of these RADs, you're looking at least starting with the axials. The AI that is also using the axial series to evaluate it found an aneurysm here. Right here on this image, it doesn't look like an aneurysm. You have to check over to the sagittal. Now, hopefully we're all using these, but it helps direct your attention when there's so much data in an image to where the pathology is. These are things that we found RADs miss quite frequently. Supraclinoid ICA aneurysms that are in plane on the axial image. Here's a 47-year-old male with subarachnoid hemorrhage and headache. Right, subarachnoid hemorrhage, young person, you're going to look for an aneurysm. What's the most common place for an aneurysm? Circle of Willis. Where are we here? Skull base. Not a common place for an aneurysm, but guess what? Left pica, 5-millimeter aneurysm. We found 2 of these in our study. This was a common miss because it's not a common location for us as radiologists to look for. Step number 4, categorize the false positives. You know 52% positive predictive value, there's going to be false positives. But can you put them into categories of a few different things? Set the expectations for your radiologist that they're going to see them. Makes it easier for them to dismiss this. If you don't tell them that it's going to call a calcified dural plaque, the RAD's going to look at it and be like, this is a stupid model. It's really not smart enough. I'm not going. They're going to dismiss it. You don't want the RADs to dismiss it because there's so much value. So categorize the false positives. Now, it's really about the balance. So again, it's not any single number, but the positive predictive value, if it's low, you have to be weighed out by something else, right? You have to be weighed out by being able to predict the false positives, categorize them, set expectations, and also have enough wow cases. Summarize and decide. So step 1, real-world performance was pretty good. AI significantly enhanced the detection of brain aneurysms, 24%, amazing. We did have a lot of wow cases, and when we showed these to our radiologists, that helped them feel that the model was useful to them. And then false positives, you know, they're common, not common with respect to the prevalence, but they're fairly common, but they're easy for RADs to dismiss, and we can teach them about it. So what did we decide? Move forward with this deployment. All right, let's go through example number 2 to show you something different. So this was a pneumothorax model on a chest x-ray. Now, chest x-ray is half of what we do. We do 13 million chest x-rays a year in my practice. So having a chest x-ray model is going to be really important for us. I was very excited about this. So step 1, evaluate model performance. Now, in this case, again, we analyzed way more cases, massive number of cases. Why? Prevalence of disease, really small. Now, we're looking at all of our patients, our outpatients, our inpatients, and our ED. We were combining them all together. Super small actual prevalence. What is that going to do? It's going to affect your positive predictive value. So 34% positive predictive value, actually not too bad in the setting of such a low prevalence. But remember, it is affected by your sensitivity. The sensitivity is even less than it was on the FDA statistics. Step number 2, actually, before we get to that, because this is a super fascinating thing that we found. Remember, prevalence has such an effect. What if you look at your data and you split it up into different categories? So here's the FDA data, first column, second column is the data I just showed you. Well, what if you split that up into your ED patients, your outpatients, and your inpatients? When you do that, prevalence is the second row. Look at the difference in prevalence between ED outpatient and inpatient. And with that, look at your inpatient numbers. Way better positive predictive value, way better numbers. And this is why you'll see some of the AI vendors just selling the model on a certain portion of your population. And you can do this if you want to improve your outcome and your RAD acceptance. All right, so step 2, did it enhance detection? In this case, nothing, none. There was not a single case that the AI found that the RAD hadn't, and actually there were a bunch that the RAD detected that the AI did not. Wow cases, well generally the wow cases come from your enhanced detection. And here we found no wow cases. There was no enhanced detection, no wow cases. So now look at your scale here, really not doing so well. Nothing to pull down your low positive predictive value to make it balance out because there were no wow cases. Now let's talk about the pitfalls before I just talk to you about false positives and categorizing false positives. But there's also going to be false negatives. So here are the false negative cases within that list. Missing 17 pneumothoraces is a lot. That's hard to convince RADs that your model is going to be good enough when you see this. And in fact, when one of them was really big. Here's that case. Maybe hard to see in the light here, but here's a CT. No RAD is going to trust a model that misses something like this, right? Sensitivity, not good enough in this case. All right, well, we were able to categorize our false positives, but there were a lot of them. And some of them, which we can talk about in some other time, is orchestration errors. That's hard for a RAD to dismiss. Orchestration is sort of a background process that most people don't know about. Really important in the accuracy, but it's hard to explain it to radiologists why it's missing those. And then some of the things like skin folds, we have issues with those too in real life, so it's not really helping you. This was actually really hurting. So this case, summarize and decide, real world performance was unfortunately far inferior to the FDA clearance data. The AI actually didn't enhance the detection. Remember, enhanced detection rate, use that instead of RAD misses. There were no wow cases, nothing to help balance out that low positive predictive value. And there were AI pitfalls, false positives, false negatives, that were just clinically unacceptable. That no matter how many wow cases you have, probably not going to be able to balance out something like this. So what did we decide? Not worthy of clinical deployment. This is FDA cleared. We did not deploy it in our practice because we went through this 5-step process. All right, so what I talked to you about today, number 1, creating best practices is really essential for us to move AI over to standard of care. This is just one out of many. But it's important for all of us to think about how are we going to do this so people can more plug and play their models. We shouldn't have everyone recreating the wheel. We need to share this information with the rest of the profession. Number 2, we talked about a 5-step model for clinical AI evaluation, for accuracy evaluation. Again, it's just not based on any single number. It's based on a few factors. So if you take this 5-step model, evaluate performance on your data, calculate your enhanced detection rate, identify your wow cases, categorize your pitfalls, and then you'll be able to summarize and decide. With that, I'd like to say thank you.
Thank you, Dr. Kottler. That was incredible. All right, and we have one more speaker before we break into the question section. And Mohammed, I have to use my phone to read your center, which is very long. But so Dr. Mohammed Mamdani is Vice President of Data Science and Advanced Analytics at Unity Health Toronto and Director of the University of Toronto Temerty Center for Artificial Intelligence Research and Education in Medicine. TCARM, is that how we say it? Wonderful, welcome. Welcome up.
Thank you.
Thanks.
Thanks. It's a pleasure to be here. And I have this really unfortunate task of following Nigam and Nina. So my goal is just to keep you awake. Hopefully that'll be successful. I come from a place called Toronto in Canada. It's a really nice city in the summer. Don't advise you to come in the winter. You can if you like, but summers are wonderful there. And I'm at a place called the University of Toronto, but also Unity Health Toronto, which is St. Joseph's, St. Michael's, and Providence Health in Toronto. And I'm going to focus on our St. Michael's site. It's an inner city teaching hospital. We take care of the sick and the poor in Toronto. And just to give you a few stats, we have about 500 beds, about 80,000 emergency department visits a year, about 500,000 ambulatory visits a year, and about 25,000 inpatient visits a year. Over 6,000 staff, over 900 physicians, over 1,600 nurses. Now, something unique about our place is that we're the only hospital in the country that has declared AI as a strategic pillar. We have 8 strategic pillars and 3 core pillars, and AI is one of our core pillars. What that means is that the leadership has bought in, the organization has bought in, and I get a team. So my team is a team of about 30 data scientists. So it's a fairly sizable team. I'll tell you why it's so big. But we've developed and deployed now, so not just writing papers, we've actually deployed over 40 AI solutions that are live running in our hospital right now. So I can tell you a little bit about how we're structured. So what does the team look like? The first team is our data integration and governance team. Why do we have a data integration and governance team? We will be joining the Epic Army soon. So basically, we will become an Epic hospital. We are, I think they call it best in class. Basically, it means a disaster. We have over 50 source systems that don't talk to each other. It's pretty comical, actually. How do you get all of these data points to talk to each other and integrate? How do you do it in real time? Because a lot of these solutions are effective if you leverage data in real time. How do you clean the data in real time and feed it to ML algorithms that spit out results and then feed it back to clinicians in real time? That's a lot of data engineering. So we have data engineers, ETL developers, those sorts of folks in this group who are responsible for grabbing the data, scrubbing it, cleaning it in real time, feeding it to our ML algorithms, maintaining the pipelines. That's what they do. And then there's a second team. This is the fun team, right? They get to build the machine learning models, optimization algorithms, that sort of stuff. So that's where you do the cool model building. And then, of course, we say, all right, well, that's great, but how do you communicate the results? Do you give percentages? Do you actually give it to them every 10 minutes, or do they only round once a day? What's their workflow like? So we have a whole team that's dedicated to product development. And these folks is actually headed up by an artist. He's a musician. And I don't know if he had a midlife crisis, but he went and did a Master of Science in Applied Computing. But his whole passion is, how do I actually look at human-AI interaction? How do I look at design? I want to know about fonts and colors and solutions that people will actually use. So in this group, we have human factors experts, designers, software developers that will actually build a solution after understanding workflow and what people want to see. And then, of course, the last team, which is really core. I don't know about you, but I'm an academic myself, and I'll tell you, I can't manage to save my life. So we need really good disciplined project managers to keep data scientists going and have timelines, milestones, deliverables. But we also need people who understand human behavior and change management. So people who can go in and say, I know you don't like this, but tell me why. Or is this where it fits into your workflow? Let me actually make sure that it's actually, you're doing it okay. And then, of course, I'm going to bring muffins to your meetings because I know people are really stressed out right now. So these are the folks who actually do the human side of things and really make sure that we deploy properly. So what does a model look like? Our model is very simple. Our data scientists do not get to ask the questions. So that's rule number 1. The questions have to come from the ground. They have to come from our frontline staff. We can have senior leadership buy-in, that's fine, but that's not where the action happens. If we don't have an engaged clinician, we do not do a project because the clinicians become the champion. So anyone can ask a question, and we have an intake form. If you ask a question, you have to go through this process, and it is priority driven. So we thought nobody's going to take the time to fill out these forms. It's not that long. It just basically asks you, what is the issue you're trying to solve? What are you doing now? And where do you expect the future to go in terms of a solution that may be able to help you? But we also have a little box. And this is the box that we're a bit famous for. It's the outcomes box. And you have to fill that out. And the choices are very simple. What are you going to impact? And your options are death, readmission, length of stay, human effort, cost, and other. And if you click other, and that's the only box you click, you're automatically deprioritized. So we're fairly clear in terms of what we want to impact. And then we also ask you, by how much are you going to expect to prove things? And you have to give us a number. So if you say, I'm going to reduce mortality by 10%, great, we're going to hold you to it, because after we deploy, we're going to monitor the change in outcomes. And if we don't meet that metric, we have a discussion about shutting it down or keeping it going, as Nigam had said. So again, we're very process-driven. And then we actually say, all right, if you actually propose the idea, you have to spend a lot of time with us. And by the way, it's not just you. On the intake form, there's actually signatures. You as the lead, but your program director, your medical director, and your division and department head. The whole community has to buy in and say, this is a problem for all of us, not for just this one person. Then, of course, we say, all right, we're going to meet every 2 weeks for the next 6 months, or however long it takes to develop the solution. You have to be at every single one of those meetings. In fact, you're driving most of these meetings because you own this. The other thing we also kind of ask, and this sounds a little bit awkward and strange, but we also have conversations around, tell us about the influencers in your group. Because if you're young and up and coming and you have these brilliant ideas, and there's a senior person who's going to say, no, I don't like it, it's not going to happen. Whoever those influencers are, we need them to be part of the team. Because they're the ones that are going to drive change and adoption. Because these are the people that everyone looks to, right? So then we actually go into this intensive exercise where we have data scientists, clinicians, engineers, all sorts of folks really meeting regularly to develop that solution under the direction of the end users. And then, of course, we deploy. And that's where we have fairly rigorous evaluation and maintenance processes. You can imagine when we first started off, we were an academic group, a bunch of data scientists playing and wanting to build models and such. And then, of course, by accident, we realized, wait a minute, they're in production. If something goes down, we have to be on call. So our teams actually, we take call, right? Because if something breaks at 2 a.m., somebody's got to respond to that. And it's going to be our IT team. But if something happens with the algorithm, our folks have to respond. So people have to take on that responsibility, knowing it's not just a research project that you can work on in the daytime. This is an ongoing initiative. So here's some examples of the types of AI solutions that we deploy. I'm just going to give you 3. We have over 40 of these. And I'm going to stay away from medical imaging examples because I think we've had quite a few, and this is the focus of this session. We only have, we're just getting warmed up in the medical imaging space. I think we have a couple of examples there, but I'm going to focus on the non-medical imaging ones. The first one is actually fairly simple. Our nurse team came to us, and they said, okay, just humor us. It's going to sound boring, but it's really not. It's one of our top 3 stressors. It's around staffing allocation. It drives us nuts. We said, okay, what's the issue? They said, okay, well, when we assign our nurses to the different zones in the emergency department, we have all sorts of rules. A junior nurse has to be with a senior nurse, has to be with a team lead, can't work in the same zone with the same person over a 48-hour period. There's all these rules, and it drives us nuts because as soon as somebody calls in sick, we got to do the whole thing all over again. And it takes us between 2 to 4 hours every day, and our repeat rate or error rate is around 21%. We said, okay, that's pretty ridiculous. So we created this algorithm. It's a fairly sophisticated optimization algorithm where whenever there's a new hire, you put in a new nurse. Otherwise, you don't have to do anything. It actually tracks all the nurses. So it knows who works where with whom. And you click a button, and it'll actually allocate for the next 4 days to your allocation schedule. And if somebody calls in sick, you just type in sick, you click it, and it'll redo the whole thing. Now, there's all sorts of social issues as well, because somebody will say, well, I want to work with my friend who's working here. And so there's a little bit of that. But what we've noticed is after deployment, we went from 2 to 4 hours every day to under 15 minutes. And the repeat or error rate went from 21% to under 5%. Right? So again, value to these nurses. And this is the one tool out of everything we've created that if we take it down for maintenance or upgrades, we hear screaming. They do not want us to touch this thing. Then there's another one. I'm going to use a natural language processing example. It's called Muskrat, Multiple Sclerosis Reporting and Analytics Tool. Our clinicians in our multiple sclerosis clinic, we have the largest one in Canada, so we see a lot of multiple sclerosis patients. And this is a chronic condition, so you've got tons of information that you have to go through, right? So our junior folks, our residents and our fellows in particular, and some of our attendings, but more our residents and our fellows, and our drug navigators as well, would complain about this. They would say, okay, so I just saw a patient, finished at 4 p.m. I'm going to see another patient at 4:10 p.m. This person has 7 years of history to go through. How am I going to get through all of this? And it's hard, right? So we sat down with them, and they said, here's what we'd like to see. Like, if you could actually have NLP go through this 7 years of history and just summarize for us on a timeline. And that's basically what the visual is. It's a timeline. It'll say, over the past 7 years, this patient had a relapse here, here, and here. So it's very visual. They had a new T2 lesion on their MRI here and here. Their EDSS score is this. You tried this drug 4 years ago, switched this, and now they're on these medications. And if you're interested, you could say, I wonder what happened with this. There's a T2 lesion here. It'll actually pull up the radiology report for you. Or if you click on something else, it'll pull up the note from that visit as well. It just saves an incredible amount of time, right? And so that's been deployed for a few years now. And it goes through 7 years of history in maybe 2 seconds. So it's very quick. And the variables that the clinicians had wanted, we've shown well over 90% accuracy in those variables. The last one I'll tell you is about our clinical prediction tool, our early warning system. So our internists came to us and they said, all right, so there's about 1 in 12 patients roughly that die in our internal medicine unit. And our problem is early detection. So a lot of people have done this. I get it. You know, the UK has the news algorithm. And we actually have to step back and say, how are we going to add value for all the stuff that's already out there? And how are we going to gain your trust? Because mortality is a big thing. And they said, yeah, you know, those are good questions. So we actually spent several months on the floors actually asking our doctors, nurses, and our residents, because there's this clinical validation that is far more important than your AUC metrics, as Nina has pointed out. So we were able to collect over 3,000 clinician predictions, because we asked them, do you think this patient's going to die or go to the ICU in real time? And so over 3,000 clinician predictions, so we knew what the baseline was. And I think as clinicians, sometimes we're a bit arrogant thinking we know a lot better than we do. We're awful at prognostication. So we didn't have that high of a bar to move. It was actually pretty, we thought it would be reasonable. But what we noticed is our clinicians beat news pretty easily. So we would never deploy news. It just, our clinicians do better. So we have this algorithm. It's now based on an XGBoost model. It runs every hour on the hour. So it ingests data. It's been trained on over 20,000 patients worth of data. And what it does is it predicts in the next 48 hours if this patient's going to die or go to the ICU. And it's automated now to page the medical team. So our protocol, as soon as the medical team is paged, they have to see the patient within 2 hours of being paged. It was deployed in October of 2020 during the pandemic because we saw our mortality rates go high. And after about 2 years of deployment, we're just about to write the paper now. There's about a 26% reduction in mortality, which has been really encouraging for us. The other thing that was a side effect of this that we noticed is the nurses actually were using it. We didn't anticipate this would happen. But they said, you know, our nurses also, some of them get stuck with a lot of high-risk patients and the others are having it easy. So now what they do is they actually allocate staffing according to the risk levels. So the rule is that a nurse cannot have more than 2 high-risk patients, which is better for staffing. Not something anticipated. So some considerations. In terms of pre-implementation, I'll just preface this to say there's a lot of papers out there around responsible deployment of AI and all that sort of stuff. I don't find them very crunchy. So I'm just going to go over a few facets. And I loved Nigam's slide around, it was much more comprehensive than what I'm going to show you. But these are some of the things that I'm going to highlight that we struggled with as a group that's really learning as we go. One is bias assessment. Really, really important to make sure that you actually have fairness in your algorithms. Here's the challenge, though. At what point do you say it's enough? Because I'll tell you, we did look at age, young and old. We looked at sickness, sick, not so sick. We looked at sex, males and females. Did we look at race? No. We don't have race data. Did we look at gender? No. We have sex data, but not gender data. So is it unethical for us to deploy an algorithm without looking at race disparities? I would argue we don't have that data. And we could pull the algorithm and we could remove that 26% reduction in mortality. Is that ethical? So there's this kind of balance around how far do you go. The next thing is around ethics assessment. Some of our algorithms, we actually have to have, actually not some, many of them, we actually have to have ethics consultation. In many cases, we involve patients as well. For example, the algorithm around our early warning system, we actually had patients because we wanted to understand if this thing triggers, do you want to know about it? And they told us, actually, no, we don't want to know unless you're changing management. If you change management, we need a conversation. So that's our protocol. But the ethics around some of the issues that we have around identifying IV drug users, for example, in our emergency department, people who don't want to be identified, you can imagine the ethical issues there. So some projects really involve quite a bit of thought around that. Communication and clinical validation, so critical that even before you deploy, before you think about deploying, you engage your clinicians and say, is this something you want? Because if they don't want it, you just don't do it. It's not going to work. And clinical validation around understanding that it's not about the AUC, it's about understanding your benchmark. So when somebody comes and says this algorithm has 96% accuracy, I can say that's garbage because our clinicians have 98% accuracy. Whereas somebody else, another algorithm can come in and say I have 75% accuracy, and I would say that's great because our clinicians have 54. So it really depends on what you're benchmarking against. A lot of people talk about external validation, and I'll say very important, but for us at our center, do I really care if our algorithm works well in another hospital? Not really. I need it to work in mine. When you're going to deploy in other places, sure, that becomes relevant. But for me as a single center place, not really. Explainability is wonderful. I'm not a huge fan of going too deep into explainability, and I'll tell you why. We produced Shapley values, and we did a bunch of things around saying, all right, well, here are some of the key drivers of why our prediction is what it is. And because it's so singular and univariate and varied and linear in thinking, the clinicians would tell us, I already know this. The magic is not in those singular things. It's about all the complex relationships where the model triggers, where they don't understand it. That's where the magic is with these algorithms. And of course, for people who say, no, I'm going to push you on that, I'll say, OK, great. Who here uses Tylenol? Anyone use acetaminophen on your patients? Does anybody know the mechanism of action of the thing? Right? We don't. But we use it. I would argue why. Then, of course, we get into soft launches. A lot of silent testing. The early warning system example that I gave you, I think we spent about almost 9 months in silent testing, making sure the model performance is good, the pipelines don't fail, all sorts of learnings and feedback around, all right, if we do X or Y, how are clinicians going to react? Having a very solid evaluation framework is really, really important for fair AI and responsible AI, making sure you do proper evaluation. We actually had an independent statistician come in and evaluate the outcomes on our early warning system because we didn't want to bias any of the approaches or findings. And of course, implementation, post-implementation, communication, reiterating expectations, making clinicians understand this thing is not perfect. It's going to miss things that you catch, and it's going to catch things you miss. But together, you're going to do much better than any one piece alone, as Nina had suggested. Really important that they actually really understand that they're not going to expect miracles to happen. And of course, again, monitoring, evaluation, and maintenance. Understanding this is not a one-time thing, that this is ongoing, and it's your responsibility to make sure that you look for things like data shift, model degradation that can happen 2 years from now. We're really struggling at things like feedback loop issues now, right? When do you train your data? How do you train it on something that is now kind of intervened on and tainted? That's going to be tough to do. So last point I'll make is that when we started with an AI lab. We did what a lot of academic centers do. We had these cool compute environments and data sets that were clean and stuff. And then we quickly realized, to both our presenters' points, the action is in the ML ops environment. It's not in the compute environment alone. There's so much more that goes into ML ops. And a progressive data governance framework that allows our data scientists to access really sensitive data is really important. I would argue we have the most progressive data governance framework in the country because we need it to enable AI. And of course, engaging our end users becomes incredibly key. So the concept of a living lab is far more important than a simple AI lab. And the last thing I'll say is the AI accelerator. What do I mean by that? We learned very painfully how not to do things when we want to take things to other hospitals. So I'll give you an example. We have an emergency department volume forecasting tool. We have this algorithm that grabs our emergency department data regularly, looks for patterns, and it scrapes, I think it uses 4 years of historical data. It scrapes weather data. So is there a snowstorm happening in Toronto? Well, you don't have to worry about it here, but in Toronto tomorrow night. Are the Raptors playing at the Scotiabank Arena tomorrow? Is there a marathon happening on Lakeshore Boulevard on Sunday? It grabs all that data, and it tells us 7 days in advance our volumes. So we can tell you today is Thursday. We can tell you tomorrow from noon to 6, there'll be 82 patients waiting. 10 of them will have mental health issues. 12 of them will be high acuity. The rest will be easier to manage. Our accuracy is between 94 to 96%, which is wonderful, right? Because it helps with staffing. Now that's great. I presented this at a conference once, and I had about a dozen hospitals come up to me afterwards and said, we want this. I said, absolutely, you can have it. And so 6 of them followed up afterwards. And we wrote them back saying, we'll give you the code. And we immediately got responses back saying, our team doesn't know R or Python. We said, okay, there's timestamp data that we use. Why don't you send us your data every day, and we'll actually run it through the algorithm. We'll send you the output. They said, great. So we actually did that for a few hospitals. And the response was, we don't understand your output because we don't have like high-quality data scientists here. And we jokingly said, do you want us to create the dashboard for you? And they said, yeah, could you? And we quickly realized we're in no position to deploy outside of our own hospital. So we actually entered into an agreement with a startup called Signal One, who would then come in and say, we'll focus on the other hospitals because clearly you're not very good at it. And I would wholeheartedly agree. So to get it to other places, we need private sector engagement, in my opinion, to be able to then bring solutions that are hospitals like ours and yours to the rest of the world. And that's how I think we're going to deliver better care for all of us. Thank you.
Awesome. All right, I'll let you all up to, come on up to these chairs. Thank you all for such incredible talks, and I think you really highlighted how complex it is to do this in the real world. So really incredible lessons learned from some extensive experience already. So we have time for about 30 minutes of questions. Like I said, if you all have questions, please feel free to come forward. But I'm going to start with, one of the things that we're talking a lot about is health equity. You all touched on these ethical considerations, concerns around bias, and started talking a little bit about how you're evaluating that. Can we just start with a question, digging in? How are you creating the structure for that evaluation? How are you making that a formal process? What lessons learned have you gotten from your initial ethical evaluations?
Okay.
Yeah.
Lesson number 1 is that ethics is much larger than just fairness. We typically use those things synonymously. We'll say fairness, equity, and ethics, and I've used them myself synonymously. But ethics is an umbrella term that encompasses other things like fiduciary responsibility, doctor-patient relationship, degree of autonomy that you grant to algorithmic agents, and so on. So ethics is much broader. It's very hard to solve for ethics. One of the things that we have found in partnership with Danton Carr, who's an ethicist on our campus, is that typically we do that using interviews, 45 minutes, hours, multiple stakeholders. And his insight is that if we can identify areas where the stakeholder values mismatch or are in collision, it gives us an early warning to where the ethical flashpoints are going to be. So that's sort of, I would say, one of our lessons. Second lesson. First lesson, fairness is smaller, ethics is much bigger. And then we can be clued into the problems by looking for value mismatches. And so the third lesson is when do we stop? Like as Muhammad was saying, that we can keep doing intersectional analyses, subgroup analyses for like 3 years and would not be done with it. Like when do we stop? So there I'm a huge fan of work by Professor Sharad Goel, who's now at Harvard. And the point he makes is let's look at the consequences. Because when we talk about fairness, that word has 2 parts. Part 1 is there a systematic difference in the algorithm's output for people who share certain characteristics? As in, does it produce a different number for me and you? And then part 2 is, as a result of that difference, is there a systematic difference in the allocation of some benefit or accrual of some benefit based on those same characteristics? We usually care about the latter. We want to make sure that there's no systematic difference in accrual of benefit. We don't care much about the systematic difference in the algorithm. But that's where we spend our energy on. Like the pooled cohort equation that I mentioned is systematically biased for 40 million Americans. But nobody gets denied a statin because of that. So we never see a headline saying the pooled cohort equation is racist. And so when we look at fairness, we start looking at the consequences and say, by protected characteristic, if I look at the model's calibration and under my policy, what will I do? is there a difference in the consequences, an accrual of benefit? And if we see no difference, we say, all right, good enough to use.
I can go next. So I think an output-driven attention to this is really helpful because ethics is a massive, massive arena. There's ethics of data, there's ethics of the model, there's ethics of how you're implementing the model, and you have to look at all of those differently. I'll talk about first the ethics of data, and I'll say that because I think one of the great things that Stanford has done is made data available publicly so that anyone could use it and create these models. In my practice, there have been many groups that have come to us and said, we want to buy your data. And to me, I had a lot of influence in discussing this with my practice because you're like, oh, well, you could make money and money could then help fund other efforts, right? So, but is it ethical to sell your data that has already been used for its primary use case? You know, if you look at what Dr. Levin wrote about it, it should be used for the common good. And so you have to think about those things, and with it, you have to know, well, who owns the data and who has access to the data, so there's a lot of legal implications as well. So we've taken a stance in our practice about selling data because I just don't think it's the right thing to do. I think you want to be able to create models that are going to be useful for a large population. The idea of creating a model that works for everyone is what we do right now, only because that's how, at least in the US, models can get cleared and sold. And if you have to create 10 models for all these different populations, you know what? It's going to work better on all those populations. So you said you only need to create models that work in your institution. That's really important. I mean, in theory, we should be doing that because you're going to get a higher output on the African-American female who's 24 than you would if you're combining that with all of the other patients in the population. However, in this industry, which is business-led, it costs money to get an FDA clearance. It takes time. It's thousands of dollars. It could be hundreds of thousands of dollars and many months if you wanted to create all of those models. So I think in the future, this is going to evolve. I think it's going to be a lot easier and easier over time to create these models, maybe not to get them all FDA cleared, or hopefully, but maybe we will move to a system where we're not trying to create a sort of one model for them all. But if you are in that instance, you have to look somewhat at some of your patient data, and most of them do not provide any subset analysis. So just having some understanding, is my patient population going to be similar to the training data, because the data is not going to work very well, and if that affects the outcome, then that's going to be important.
Yeah, I think from my perspective, and I'm going to butcher this because I'm not an ethicist, but we've had enough conversations with ethicists to kind of come at a couple of points. The first one is around principles. So we have an in-house ethicist who's fantastic. He has a small team, and there's a joint center of bioethics at the University of Toronto. They're really starting to focus on AI. And what we're finding is the academic ethicists are wonderful, but it is a bit of a different ballgame when you actually are deploying and getting your feet dirty on the ground. And our folks typically tell us, look, I understand the principles, but I don't understand exactly what you do. So there is a bit of an education that goes both ways, right? So things like precision and recall, first time our ethicists ever heard of those terms was when we started talking with them, right? But it's important for them to understand, well, what are the implications, to your point, in terms of what's the net benefit versus harm. But the second point is that things that they always tell us are, I'm going to focus on just a few things. One is that net benefit harm, right? Are we seeing a net benefit? The second is equity. I want to make sure that we're going to be equitable to different groups. And where we struggle is that it's not going to be a perfect art or science, because there will be a lot of gaps, and you will have to make human judgment calls. And those judgment calls will vary. So what we've experienced is that if we go to one ethicist who's fairly well informed, they'll give us a certain opinion. But if we go to another ethicist, and it depends on who you pick and how much they play in this area, they may give you a different opinion. Absolutely. So my sense is it's evolving. I think the more education there is both ways, where we learn about ethics, the ethicists learn about AI, I think we're going to reach towards consistency, but I don't think we're there yet.
Fascinating, yeah. Oops. Go ahead, Nigam.
It's possible to do multiple hypothesis testing with an ethicist till you get the opinion you want. I'm saying it in half jest for the very simple reason that we've been talking about learning health systems and things like that for quite a while now, 15, 20 years. And one of the provocative ethicists from Johns Hopkins, Ruth Faden, makes the argument that if you as an individual want to benefit from the collective data of others, is it not your duty to share your own? Like from a pure moral principle standpoint, if I want to benefit from millions of other people's data, it is my duty to share my own. So that is my usual opening statement about ethics in the data space. And then the second thing is, here in the US, we're in Northern America and the Western Hemisphere, we tend to follow European ethics for the most part. We forget that about half of humanity does not subscribe to the same ethical principles. And we just pretend that what the Western philosophers came up in medieval Europe is the right ethics. So just ponder that for a minute.
Yeah, very valid point. So super easy problems to solve. We've got it all done, right? Yeah. Mohammed, I'm going to pick up a little bit on your point about educating the ethicists, because I was fascinated how you were talking about the role that you expect the clinicians to play. And if ethicists are hard to educate, I find the clinicians even more of a challenge. And so talk a little bit about that piece. I mean, you expect your clinicians to play a huge role in putting together the use case and implementation and understanding it. How do you approach the education that needs to happen of those clinicians in order to be able to do all of that?
Yeah, great question. So yeah, we absolutely expect that. And if there's not that level of clinician engagement, we will not do the project. And initially we thought, nobody's going to go for this, but we have a backlog, a wait list of projects now. The engagement has been fantastic. But the way we approach things is at a place of humility, because we have to go in saying, we're not going to know the clinical realm, they're not going to know the data science realm. So the way things are typically structured is the first meeting is what we tell our clinicians, give us a mini med school. So we're going to spend a little bit of time where you're going to teach our data scientists, what is a pneumothorax? Why is it important? How do I look for it? Tell us when you look for it, what your workflow is like. Tell us about all those things from a clinical and operations perspective so we can understand. So the data science team typically walks away really enamored by, oh my gosh, we're half doctors, and now we feel so much better that we know more about this. And then, of course, the next session is we kind of understand what the clinical question is, and we say, you know what, I think maybe this approach might work. And we hone in on that. And so the next session is time for us to give an education. So the clinicians sit there, and we say, here's a mini boot camp on neural networks. Or for this, we're going to use, I don't know, we tend to do a lot of XGBoost because of the time series nature of our data. Here's what an XGBoost is. Here's what it does. Here are all the assumptions. Here's hyperparameters and how we tune things. And so the clinicians understand, oh, that's the process. And they quickly realize, so let's talk more about features and the data that goes into this algorithm and understand how you're putting those in. And you do realize that we actually look for all these sorts of parameters when we make decisions. So are you sure that you've got those in right? Because that's how the algorithm's then going to process it. So then they're going out educated and understanding the method that you're using. These are all the things that I have to be thinking about. And it's almost magic. Uniformly, I don't think we have a single exception where the next sessions are just so much easier because we start talking the same languages. It's effective that way.
Yeah, no, that's a great approach. Any thoughts? Yeah.
We've had the same experience. When you're talking about the first part, which is creating the model, you need to get that engagement, and we had the exact same experience.
Okay, yeah.
So when we created our first AI model, it was 2017. There wasn't anyone that was creating it. It was to do natural language processing as the radiologist dictated to provide clinical decision support aids for follow-up. Best practices out there, I say there's a 4-centimeter AAA. It tells me get a follow-up with a vascular surgeon and a 1-year follow-up. So how do you do that? Well, we engaged an external company because at the time we didn't have any data scientists, and they were really smart people. In fact, 3 of them or half of them were rocket scientists, literally. So like super smart people. And when I told them what we wanted, they created something, brought it back, and I was like, this is terrible. Like, we're gonna have to fire them. This is so, like, they have no idea what we wanna do. And then I was like, well, gosh, maybe it's not them, maybe it's me. And we changed how we did everything. And I flew out there for 3 days, went through the anatomy of different parts of the body, talked about physiology, talked about the terminology that we did, why the best practices were created. Second day, exactly what you said, they went through their stuff, they ran the model on different reports, came back to me, and we had this wonderful collaboration. All of a sudden, the model output was phenomenal. And that's a really important part of creation. I don't know that it's always happening because, at least in your institution, you get that ability. A vendor may not be doing that. So you have to make sure that you're working closely with your vendor. On the other side, which is the deployment, and you're doing this as well, but you need to make sure that the user is going to use your tool. And I'll tell you a story. When I was at an institution where we were deploying a tool and we flew out there to educate we have a whole process because it's really hard. The team there said, hey, you're here at our hospital and you're educating our radiologists. We have 2 other AI tools that we bought as a hospital and the users are not using. Can you teach them those too? Because we want them to use those. It's a very big problem. You have to have a process around managing that because no human likes change. Change has a very, it makes us nervous in healthcare because our consequences are very high. So you have to have a really strong process there.
Nigam, you want to add anything different?
No, whatever Muhammad said.
What they said? Yeah. Good call. I think what's fascinating is I clearly, I mean, you guys are all echoing the same thoughts, and these are clearly very important steps. However, your average physician or your average clinician is very busy already. And so getting that significant amount of time that you're talking about can be challenging. I guess it's a couple. So I have my own biases here, which I'm trying to lead you guys down this path. No. How are you finding, I mean, are physicians and clinicians doing this after hours? Are they using their research time? How are you getting the time that you need to get the engagement to really create these partnerships?
Yeah, maybe I can start. I find actually the physicians not as tough as the nurses.
Yeah.
Because for us, we're an academic teaching hospital, right? So a lot of our clinician scientists have protected time. And so they have protected time to do research, and then they do the clinical work. And my value proposition when we first started to get people kind of excited about was really, really easy. What I told them was, you can go and apply for a grant, spend a year doing that, get rejected, put in your comments, address them, go another year, and maybe get your funding. And of course, you're going to under budget because you don't know how to budget. And you're going to struggle with your grant. Or I have a team of 30 people. We can get started today. And you can get a lot of great publications out of it. Because if we do something novel and we show impact, you're going to get some good publications. So that was fairly easy. Now, what happened is it snowballed. And then people started realizing there's this great resource. I don't have to worry about writing grants. I mean, I still will write grants because my CV needs to be built, but I get these free resources to build things that I'm passionate about. Then other clinicians started saying, oh, wait a minute, this is actually happening and it's working. So they started coming in, the ones who don't have as much protected time. And the nurses, we just have to accommodate their schedules. So we literally have people coming in before their shift starts, spending an hour with us because they're passionate about it.
So using their free time, which I think is a huge issue. Have you guys found miracle solutions here?
For us, because we're a private practice, and we do have academic medical centers, but the majority of our practice is private practice physicians who their job is to consult with the referring clinicians, to read studies, to do interventions, right? Their job is not to help with AI. And anything that takes them away from that makes their job harder. So what we've done in our practice, recognizing this, because you can't do this as a second job and have it scale in any way. As a private practice that doesn't have days where we give people, we actually pay people to join our team and help do this and make it easier. So these best practices were created by a team. I have a team of 12 people, many of whom are paid to not read cases, but to help create and deploy AI in a best practice way to make it easier for the rest of the practice to consume. And I think that's really important. Now, later on, when we don't have to do all of this work and it's more standard of care, you're not going to need that. But right now, early adopters, if they want to do that, they're going to need to dedicate time.
Nigam, anything?
We have the little bit of the opposite problem that our data science team is 5 FTEs. And academic medical center, everybody's seen the Gartner hype cycle and want to be on the escape velocity trajectory. So the question becomes, what is the value proposition that is the fastest to show that we can go from 5 to 30? So it's a little bit of a different problem, given that so much excitement, but not enough workforce to go from idea to value so that we can sustain it long term.
How about, just to push on that though a little bit, how about, when you're really looking at the entire multidisciplinary workflow, how do you get the nurse's time? How do you get the RT's time? How do you get the palliative care consultant time?
Yeah, so again, this N of 1 or 2, okay, so there's a whole bunch of programs for quality improvement, like the CELT, right, and so on. So we piggyback onto all of those because they've already figured out a way to get the right stakeholders at the table, because they're already trying to solve a problem. And they have nursing, they have the clinician lead, they have the operational leaders and all of them. And then we send somebody to that team. And that's a way to short circuit. Like otherwise, with a team of 5, you just can't go around doing all of those meetings just by yourself.
Yeah, that's great. I mean, I think what you're speaking to, right, in my mind, there is new models of care. There's new meaning to clinician work, right? And it is no longer just doing one-on-one with the patient. It is also being a part of, whether you call it quality improvement or clinical informatics or implementation of data science, it is a job that needs to be protected. And there are ways, I mean, you've got creative ways of turning it into their scholarly output and getting them credit that way, tying it into quality improvement, which is already reimbursed. But I think we need to rethink the workforce and what that means to be a clinician in this workforce.
Yeah, so I'll ask you a question. I mean, there was a time when
no.
allowed?
That's not allowed.
No, there was a time when CMIO was a part-time job.
Right.
And now most health systems have a full-time CMIO, or 80%.
Absolutely.
Like, what was that journey like, and what could the AI folks learn from that?
Yeah, no, I think exactly to that point. So I'm CMIO. I'm also program director for Clinical Informatics Fellowship across Stanford Medicine, and in my mind, it's really that partnership to create these learning health systems is between the data scientists and the clinical informaticists, who are their job, and they are paid to do that because there's value in it now, right? Is to work and to understand the clinical workflows and to evaluate the workflows, re-engineer them, and change the processes to be able to support this implementation, do the change management, do the communication. But I think it's important that systems recognize the value of compensating people for this work. And they have for CMIOs. I think they're starting to do it for some of these roles. But it's no longer just like ask a clinician after their 80-hour work week to come put some time in with a data scientist. And I think to the other end of that, we talk about being on the hype cycle, and I think the hype cycle for potential good and hype cycle for the end of the universe. And one of the things I think people are worried about is, will AI replace people's jobs, and what does this mean for me? How is that something you're encountering? Is that something you're educating to? How do you see people's roles evolving in this day and age?
I can start. I think you have to have a vision for where you want to go, and then you drive toward that vision. You don't make a decision without your vision, and people don't spend enough time, I think, thinking about a vision. They try to go immediately to, what are we going to do? Let's just start working on it. And I think that, having been in radiology for so many years, I feel very passionate about this specialty, and the reason why I went into it was because we have the opportunity to educate our fellows clinicians, right? We're the doctor's doctor. And so at my practice, I had to create a vision for what our future is going to be for a radiologist, and I've thought out further and further ahead. And with that, the idea that there is so much data coming into the system, right? We're already looking at morphologic imaging, some physiologic imaging, with our studies that we're reading. But now we've got AI, which is producing structured data out of the 97% unstructured. We've got molecular imaging, radiomics, genomics, proteomics. We have all of this massive amount of information that's going to be coming into the system. Who is going to take that information and contextualize it and pass it back to our referring clinician? In my mind, the perfect person is the radiologist. That's our job. Right? So if we're going to take on all of this new work, we're slammed now. We can't even get through the morphologic imaging because there's not enough radiologists. We need something to take away some of the effort to elevate us so that we can do more. Now, it doesn't mean that it's going to replace us, but you have to have a vision of where you're going. And in this future vision, if you can do something in 15 minutes that used to take 3 hours, as the keynote speaker was saying, you're saving time now to elevate your role to add in more information. So we're taking a lot of time at our practice to just make sure that people understand AI, because you can't be in the driver's seat unless you are an expert or have some expertise in it. And then with that, as we move forward, we'll start adding on more things, because I think that's what's going to improve patient care in the future, is taking all of this information and contextualizing it.
Absolutely, yeah. Any other, you guys want to add?
Yeah, I mean, I think to Nina's point, you're already working 80-hour work weeks, right? So what I often tell people is, actually, I think AI is going to make care more human, not less human, because the hope is that we're going to be able to take out some of the work that you don't like doing. You know, one of the things we're actually thinking about now, and I know there's all sorts of private sector folks who are into this, is how do you get generative AI to actually write up your admission, discharge notes, your progress notes, stuff that you don't like doing, so you can spend more time with the patient, or you can cut your 80-hour week to maybe 60 hours. So I think if it was a profession where you have your typical 40-hour work week and such, then yeah, you know what, I'd be a little bit worried, because we'd be on, like, how do we replace you? Mm-hmm. But you're not going to replace anytime soon. Like, there's so much of that other extra stuff that has to be covered, that I think, if anything, AI is going to help physicians decrease their workload, I hope, and spend more time with patients.
I'll just add one more comment quickly. I want you to be able to speak, but in everything that we've done, in all of our evaluations over the many years of deploying, we have unanimously found that user, in our case, radiologist plus AI, are better than either one alone. And so why would you be simplistic and say, I'm just going to replace you, when you can augment and elevate the standard of care?
Yeah, I think the fears of AI replacing humans are greatly exaggerated, particularly in the medical profession. And as our AIMI director, Kurt Langlois, has said several years ago, radiologists who use AI will replace radiologists who don't. And I think that can be generalized to, like, all providers, and I think it would still hold.
I've been quoting Kurt a lot lately. So you all gave us really great principles for how you're evaluating it. And going back to the idea of, you know, limited resources, limited clinician resources, limited data scientist resources, those principles of how you evaluate and prioritize become incredibly important. And you gave us some really nice structures for doing that. Unfortunately, in the real world, it never works out as well as we design, right? So I'd love to hear a little bit of your lessons learned about which algorithms they seemed like they were high priority, they seemed like they had all the right factors and didn't work. What were the lessons learned from that? How have you changed your prioritization schema? And did you actually shut them down? Because we always say we will, but then they go on forever.
So not my team yet, but Stanford has shut down the sepsis BPA alert that was launched many years ago.
Yep.
So we have shut one down, like we as an institution.
We chose not to launch one because we did our evaluation first. Right now, what we're doing is we're deploying 5 AI computer vision models out across our practice, and I think it will be reviewing 27 million exams by October. And what we said is we need to make sure that there's real value creation. We think there will be based on everything we did, but you have to determine that there's value creation. And if there's not, if the clinicians don't like it, if our users don't like it, then absolutely, you need to take it away so that you can spend your time working on something that's more important. And so that's a really important principle to do that. I will say that it takes a lot of time to make sure that you're going in the right direction, and you need to have clinician effort that's working on that together. But I think there's value in figuring that out quickly. We used to run a pilot, it would take us 6 months to figure it out. Now we do this work that I just showed you in 2 weeks. Right? You can't take 6 months, there's too many models that are coming out. That's the accuracy part. There's 2 other parts that are really important and probably even bigger differentiators. Number 1, the business case. When we evaluate an AI model, we're looking how clinically accurate it is, but also these things cost money. We have no money in the healthcare system. How are you going to pay for it? Now, when clinicians, we don't like to think of it. We want to just think about, let's be altruistic. That's why we came into medicine, and let's deploy things that are going to help patients. But it has to be sustainable. So you have to think about the business model, and if there's not an ROI for someone to buy it, you're not going to be able to use it. So that's a really important one. The third one is the technical capability of the actual team, if you're buying a model, that can deploy in your environment. The amount of work that people do on AI is such a small component. I think there was a slide on this, right? Most of the difficulty in deploying AI and using it, and a lot of the reason why it's not out there, is because it is so hard to take that crazy amount of data that you have in all those silos, move it to the AI, create a system that can orchestrate, make sure then the AI reviews it, sends it back, you get those results before the RAD opens a study. There's so much complexity in that. We have unanimously found that to be one of the biggest differentiators right now.
Absolutely, yeah.
Did you want to? I think we also have a question from the audience.
We have a question from online. It's an online participant, Dr. Hicks. So the speakers this morning presented on the importance of choosing tools carefully to provide real value. How short are cycles of evaluation to decide whether to continue a model evaluation? Do you use sprint cycles to get to decisions quickly, or do you use a decision tool to decide length of time to evaluate a model?
So continuing along the same theme. Go for it, Mohammed.
All right, terrific. Just on the previous point, we're actually in the process of shutting down 2 projects. And if people are watching, you know who you are. But we do have this kind of fairly extensive feasibility assessment that we do.
Yeah.
I would say if I had to peg our success to failure ratio, it'd be probably 70 to 30, 70 success, 30 to 30 failure. That's pretty high, I would think. But we do cut off projects if it seems like a great idea, but it just in the feasibility doesn't kind of go through. And sorry, could we reiterate the last question?
So basically, along the same lines of, what are your cycles for evaluating? Like, are you doing sprints? Or how long are you evaluating them?
Yeah. So we actually have a few things that we do. So there's process metrics that we take on, especially during silent testing. So we'll have a look at things like, how often does the pipeline fail? Does the model perform as well as we're expecting it to? And then we also have, on the actual evaluation post-deployment, the time frame really depends on the question that you're asking, because if you have something that doesn't happen very often, you're going to have an extended time frame.
Exactly,
right?
yeah.
So for example, with our early warning system, we needed enough deaths to say, are we actually making a reduction in mortality? And to accumulate the appropriate number of deaths, we do a sample size calculation, all that sort of stuff. It was about 18 months, because we're just one center, right? So it took a while to do a proper evaluation. Other things, like the nurse assignment tool, that, like, you flick the switch and it was like within a few weeks, you just know you're hitting the performance. So I think evaluation can vary from as few as days to weeks to a year, 2 years maybe, depending on the outcomes and stuff you're looking at. The other thing I'll highlight too is it's really important that people consider mixed methodologies. There are a lot of times where the numbers are going to tell you one story, but the stories that you hear from clinicians, from patients in particular as well, they may tell you an entirely different story. And those stories may actually trump the numbers you see.
Absolutely. All right, I think we are out of time. I was not doing a great job of watching the clock, but thank you all for the very lovely conversation, and really learned a lot.
Thank you.